All right, hello everyone, and officially welcome to our second STEM Talks of the year. As you can kind of see from the pictures and from the title, today's STEM Talks, or our career panel, is focused on the bones of the body. So basically how this event will work is we have three healthcare panelists that will talk about what their career entails and how it relates to the bones of the body. So they're first going to talk about how they got to where they are, their education journey, and then they will answer any questions you have after they all present. So we're each going to talk for 5 to 10 minutes, and then again, we'll have that open Q&A where we'll cover questions that you pre-submitted or questions that you're going to put in the chat. So again, throughout the session, feel free to put questions in the chat. You can also raise your hand at the end if you want to ask your question live. In terms of the welcome session, I always forget to do this, but Trisha, can you launch a welcome poll? We have a welcome poll where we want to just see, like, what do you know about the bones of the body? Are you interested in the bones? Have you come to our event before? Just so we generally know who's in the audience right now when we are asking questions and learning about what's happening today. For those of you that are here for the certificate program, great. All you have to do to count your attendance is have your first and last name spelled properly, and then we'll take your attendance directly from Zoom. For those of you that have no idea what the certificate program is, I will briefly cover it. So certificate program is the program that our team hosts, where we actually give you a certificate at the end of the year if you come to 7 of our events. So specifically, if you attend either 7 career panels or virtual interactive activities or even PA day sessions, we will give you a certificate signed by senior UHN leadership. And in addition, if you are part of the health and wellness program at your school, we'll also give you either the medical terminology or lab practices credit. So it's kind of a fun program. This is one of the eligible events, and we have many of them coming throughout the course of the school year. So here's just a few of them coming up in the next few months. We have nursing, medicine, neuroscience. It's going to be kind of a fun year of programming. So this is the QR code. If you haven't yet registered for the program, I'll leave it up for 2 seconds, but Trisha's also putting this in the chat. So you are kind of good to go there. And beyond that, as you can see, I am recording the session. So just if you do not want to be on camera or don't want your audio heard, please just keep that off throughout the session so we also don't distract the speakers. So for the sake of time, I'm just going to get us started. So Atusa, whenever you are ready, feel free to take over screen share and talk about your fun research job.
Oh, hi everyone. My name is Atusa, and currently I'm a PhD student in biomedical engineering at University of Toronto. I'm also a research technician in the Shoulder Arthritis Institute at UHN. So as part of my background, I'm an immigrant. So I was born in Iran. I moved to Canada for my senior high school year, and then I got accepted to U of T. So the whole family moved to Toronto. And after I finished my undergrad, I decided to volunteer for a year. So I joined Dr. Viswanathan's lab. And I really liked the environment there. I liked the programs that were going on in the lab. So I started my master's degree. And while I was actually defending my master's, I also started my PhD project. So they asked me to put some of the stuff that I enjoy doing. So I enjoy listening to music. I love attending concerts, always in my Tay Swift era. I love watching stand-up comedies, and I just like to go on walks in my free time because it just gives me time to just relax and not think about anything. So as I mentioned, for my education, I did both my bachelor's and master's at U of T. I'm doing my PhD at U of T too. So the topic of my work is osteoarthritis. So in our lab, we basically study 3 different things. So stem cells, macrophages, and the gut joint axis to find treatments for osteoarthritis or OA. And now very briefly, a lot of you might not know what OA is. So OA is basically a joint disease, and during OA, what happens is that the cartilage that covers the bones, they start to wear out, and you basically get bone on bone, and they start rubbing against each other, and it's very painful, and it makes a lot of difficulties for patients. So here I just decided to kind of explain what like macrophages, stem cells, and gut microbiome are. So macrophages are a type of white blood cells that can protect you against infection, and they do something called phagocytosis. So they basically eat all the cells that are infected or the debris and anything that's basically not right in the body. And the second one is the stem cells. So stem cells are kind of specialized cells that can turn into, for example, fat cells, muscles, red blood cells, depending on what the body needs and the environment that they're in. And the gut microbiome is made up of a lot of different bacteria, viruses, and other microorganisms that can help you digest the food, make vitamins, and kind of help your immune system. So as I mentioned, so my research project focuses on understanding the mechanisms that drive OA progression. And osteoarthritis, a lot of people associate it with, old age, and they don't think that what they do right now really matters. But actually, all of these health choices that we're making early in our life, like the food that we eat, the amount of physical activity that we have, our gut health, they all can have long-term effects on our joints. So a weekend in my life is pretty versatile. So I do my experiments usually in the mornings, and it really depends on the type of experiments that I'm doing. If I'm working with cells, tissues, etc. I usually do data analysis in the afternoon, so after I complete my experiments. And we have weekly lab meetings and presentations that we do in our lab so we can show our project progress to the lab members, and we can get their opinions from for different projects that we're doing and see if we're doing it right. And we also have weekly meeting updates with our PI. So again, we talk about the progress of our research program. And if you have any problems, then that's when you have to like go over and explain what your problem is and try to figure out how to fix it. Other than that, because I've been in the same lab for a while, so now I do a lot of trainings in the lab. So when we get volunteers or new students, I train them with different techniques that they have to do, like PCR, cell culture, etc. And so the last slide I think that I have is why I chose this path, basically. So I feel like the effect of OA is very diminished when you talk with people and they don't really understand how many people actually have OA. So currently 6 million Canadians live with osteoarthritis. And by 2040, that's going to be raised to 9 million, which is a lot. So we're really trying to discover new treatments that we can use to slow down OA or prevent the progression of OA, and that way try to improve the quality of life for people. So yeah, I think that's it. That's it for me.
My name's Josh, and I'm a master's student in kinesiology at the University of Toronto. I'm also a research trainee at the Schroeder Pain Assessment and Rehabilitation Research Clinic at Toronto Rehab Institute. A little bit of background, I was born in Toronto. I moved to Hamilton when I was really young, and I grew up in Guelph. I'm currently working at Spark, completing my master's there, and doing clinical research. In my spare time, I work as a strength and conditioning coach. I compete in strongman, and I do clinical research. As far as education goes, I did my undergraduate degree at the University of Guelph Humber, where I got a dual degree diploma in health and fitness and kinesiology. And then after that, actually, I graduated in 2013. I went and I worked in industry for the last 10 years. And I came back to do my master's just last year after not being in academia for a really long time. So when you're getting into your undergrad, actually, that's a good point as well. I graduated high school and I didn't go to university until 3 years later. I wasn't sure what I wanted to do. So there's no pressure necessarily in terms of jumping right into an undergraduate degree. And then even when you finish that, if you are interested in research, you don't have to jump right into it. You can explore and sort of work in industry and figure out what you're actually interested in before you jump into things. So to get into what I'm doing and my research interest, currently I'm interested in clinical research where we aim to sort of find treatments or interventions that can enhance people's quality of life. And the current project I'm working on is pain phenotyping knee osteoarthritis patients. So thank you, Atusa, for introducing osteoarthritis. Now I don't have to. So specifically Phenotyping is when we try to create subgroups within a population of people. So specifically, our lab is interested in chronic pain. And with my research project, we're looking at people who are called non-responders to total knee replacement. So if you have really advanced osteoarthritis and medications are not helping you manage pain and your ability to function as an individual, last sort of resort treatment is total knee replacement, where we take out the joint and we replace it with a new one. You would think that you take out the injured joint, the degenerating tissue, and you put in fresh new tissue or fresh new joint. You'd think that pain would go away, but not all of the participants or not all patients have their pain resolve and their physical function resume. So actually, there's about 38% of patients who undergo total knee replacement remain in persistent pain. And in Canada, at least 13% of patients report that they're dissatisfied with their surgery. So what we're trying to do is we're trying to subgroup these osteoarthritis patients who are going for knee replacement. And we're trying to see if we can find similarities between people who are non-responders. So what we're doing is we're trying to subgroup these patients into what we call the 3N pain mechanisms. So there's three main mechanisms. You can have pain that's sort of derived from a disease or an injury of the nerve. You can have pain that's derived from tissue damage. And then we have a third mechanism called nociplastic pain, which is when you have pain without observable tissue damage or nerve injury. And it's difficult to, when there's no specific injury injury present, it's hard to figure out what to do and how to treat that. So what we're trying to do is figure out the underlying pain mechanism that might be involved in this non-responder group. And then from that point, maybe we can figure out a better care path for those patients rather than unnecessarily undergoing surgery or a treatment before they go for surgery so that the pain is actually resolved after the surgery. So a week in the life of doing clinical research. At this point, because my study is we're seeing patients 1 year or before the time of surgery, and then we're seeing them again at the 12-month time point. So I'm in the middle right now. There's not a whole lot of data collection and hard science happening. So a lot of my day right now is reading. We're reviewing literature and we're developing projects that can branch off of what we're currently doing, and even projects that might be relevant to the rehabilitation process after the surgery. Being able to read literature and write grants and things is really important in a researcher's life. We have to be able to we have to be able to afford the research that we're doing. So being able to write for grants and reading the literature so that you know what's already available and have a good place to start from when you're doing research. Another big component is writing, which I mentioned comes from reading as well. We have to be able to write for scholarships and grants for future proposals and future research because they have to be funded somehow. Some of my time is also in data analysis from the data we collected at the pre-surgery time point, and just getting things set up so that when I get the 12-month follow-up data, things are nice and smooth. We have a bi-weekly lab meeting where we meet with all together and we discuss the current projects going on in the lab. I also have one-on-one meetings with the PI of the lab where we discuss the project progress and any maybe issues that we might be having or things that we need to work on. And then finally, I'm also a teaching assistant in the kinesiology program at University of Toronto. So I spend time teaching this semester first-year students in the physical activity and healthy lifestyle course. So then the importance of my research, there's 75,000 total knee replacement surgeries on average in Canada every year. As I mentioned before, about 38% of those people are likely to remain in persistent pain after surgery. And in Canada, about 13% of that are unsatisfied with their surgery. And 13% is a smaller percentage, but of a large number of people, 75,000, that's a lot of people in Canada who are going for surgery remaining in pain and then not happy that they went for surgery. Another consideration there is that most patients that are going for this surgery are over 60. And we know from other research that older adults just do not recover very well. They don't recover fully back to their baseline after surgery. So that 13% of people who are not satisfied are going through a surgery that they're not necessarily going to fully recover from, and they're still in pain. So that may be an inappropriate intervention for those people. So my research is hopefully going to increase the success rate for that surgery and increase the quality of life for thousands of Canadians who are having non-response to total knee replacement.
My name is Arlene, and I am currently working with rheumatology department, mostly with the outpatient as the clinical research coordinator. I came into Canada being an internationally educated nurse. So I am a gardener, a cook, a cheerleader for my kids, and my kids do play competitive volleyball. I do love continuing education and travel. So with education, you can see on the right side there, that was circa 1990s. I've been a registered nurse from the Philippines, came in 2005, and I did my RN pathways with George Brown as an internationally educated nurse. I also have worked with the country in Jeddah in Kingdom of Saudi Arabia for 2 years prior to coming to Canada. I have been with UHN from 2007 to the present, so been with UHN now for about 17 years. So the first 7 years with UHN, I've been doing bedside care nursing with the nursing resource team, and that is just like a little department, sort of like an agency of nurses within UHN, wherein we get deployed to different departments in UHN, be it with internal medicine, surgical floors, the ICUs, ERs, and then the other specialties like transplant, in cardiovascular, in urology, and all the other things, including the Western with neurology, with orthopedics, and the cardiac floors too as well. So right now with the rheumatology outpatient clinic, it is also one of the largest kind in Canada. And as you see, I have listed the following medical conditions that is being addressed, or we see all these medical conditions within our rheumatology outpatient clinic. We also do have the Center for Prognosis Studies, which does conduct clinical trials in lupus and PSA, or what we call the psoriatic arthritis. So one of the main things that we do address is what we call ankylosing spondylitis, or AS. And I believe Josh might have encountered probably some of the researches too with SPARC. This is tied up with SPARC too as well. So as you know, any arthritis is any swelling or tenderness in one of more of your joints, and it is degenerative. So AS is considered as the arthritis of your spine. You can see the difference between the healthy spine and one that has AS, and then the natural curvature of your spine do change over time. In some cases, young adults it takes some time for young adults to be diagnosed with AS, and most especially if you are highly active in sports. Early signs and symptoms could include pain and stiffness on your lower back and on your hips. And you might see this or prior to in the last 50 or something years, this might not have been called AS, but if you are familiar with the Hunchback of Notre Dame, So those people with curvatures of their spine, most likely, if way back then, could have been diagnosed with AS, because the joints on your spine do fuse at some point, and there will be like hard capacity for one person to fully mobilize oneself if you have this kind of condition. So another condition with rheumatology is what we call rheumatoid arthritis. And it is the chronic inflammatory disorder that can affect your joints. On the picture, you could see there some contractures of the fingers of the hands. That is the joint spaces in your hands. Or it could affect to the joints on your elbows or your knees. And then there are a lot other condition with which include your skin, the eyes. The eyes we called part of with arthritis people that they do suffer from iritis or uveitis. And rheumatoid arthritis is an autoimmune disorder. Your body or your immune system mistakenly attack your own body tissues and cells, or in this case, your joint spaces. So unlike with the wear and tear of your osteoarthritis, rheumatoid arthritis affects the lining of your joints, and it does cause painful swelling and result in bone erosion and then deformities, as what you can see in the picture. So with regards to my work with rheumatology department, I do handle patients that we give treatment, what we call biologics or biological products. These are wide range of products that could be your vaccines, any blood or blood components, any therapy for tissues or combination therapies. So your biologics can be composed of sugars, proteins, nucleic acids, or complex combination of any substances. It is taken from either natural resources like human, animal, or any microorganism. And it could be produced with biotechnology. So there is a list of examples that I do actually have listed here. That is the common medications that I do administer as part of therapy. Infliximab, or what we call with common brand names like Remicade, Inflectra, Avsola, and Renflexis. Also, we have rituximab, Rituxan, Ruxience, and Riximio. We have tocilizumab, Actemra, adalimumab, Humira, and golimumab, your Symphony. So how does biologic infusion or even injection is different from any other medications to treat certain medical conditions? So these are chemically synthesized products with complex mixtures in it. So with regards to infliximab, it is actually a portion that is derived from a human component and that of murine. So murine is actually anything that a species of murine could be your rats, your rodents, and the mice. So a component of that is the protein to actually make the medication or the drug. So you can see there that infliximab is used for any variety of inflammatory conditions like your RA and the AS that we have mentioned earlier, plus also with people with irritable bowel syndrome, including Crohn's and colitis. So what does infliximab do is it is an anti-TNF inhibitor or blocker. It actually blocks this kind of component that is naturally occurring in our immune system, and it suppresses that action so that the inflammation is being stopped. So here, I took a picture, or this part of rheumatology also deals with scleroderma. And scleroderma is not only with your skin, it also could affect multiple organ systems in the body. And one of the medication that I do provide, or our clinic do provide, is Actemra for these patients. We also have here the team for psoriatic arthritis. And on the picture on your left, you could see those top-notch scientists and physicians we do have within our department. And on the back, there is a huge amount of team that is involved with research for the treatment of PSA and other medical conditions within rheumatology. So how is it with me and infusions during the week? So I wrote down there simply, it's giving medications to these individuals or our patient population. It's infusion, infusion, injection, infusion, infusion, injection, and then it repeats. Every single individual or patient does need therapy as prescribed when all other initial modalities of treatment have failed. And that's when biologics come into place. So a person could come every 4, 6, 8, 12 weeks, or with the cases of rituximab, patients do come every 6 months for that. Also, I do a lot of clinical documentation. Every visit is equivalent to a lot of clinical documentation. There are also clinical trials for new and upcoming treatment modalities, and we do actually communicate with principal investigators, sponsors, and other research staff. I also am highly I highly communicate with a lot of our medical physicians and other healthcare practitioners, and also with the patient support programs. This is in relation with the treatment modalities or the biologics that these patients do receive. And of course, there are a lot of administrative duties too as well. So what is the importance of my job, research, and career? So as I am a nurse, and we do know that nurses wear many hats and sometimes a jack of all trades. You will find nurses in all fields of medicine or even outside of healthcare. And by combining research, caring for people, improving their lives by improving their activities of daily living, and at the same time, enriching oneself or me and other healthcare providers, all of this, fall in the bucket of what I do in a daily basis within UHN. I believe that's it, and thank you.
Thanks, Arlene. A lot of new terms that we all learned together. So it was like an exciting mini chat about your job. So we are now in the Q&A portion of the talk. So I'm going to bring all our speakers back on screen. Okay, so we do have a lot of questions. A lot of them are private message to me as well. But let's start with the very simple, straightforward starting question. Why bones? Like, why do you think bones was cool? I guess a lot of kids don't think about that when they are in high school. That could be a career path. And maybe we can just go in order of the speakers for the first question. So Tusa, why?
Sure. So actually for me, it was completely a coincidence. Like I didn't enter the lab because I like bone. I like it's not bad, like I like it now, but I like that wasn't like my focus when I was entering my like lab stuff. So I really like working with macrophages actually. And Samia's lab worked with macrophages a lot, and the bone kind of comes with it. So yeah, I like macrophages. I joined the lab and I learned about osteoarthritis. I liked it. I stayed.
That's good. You don't have to know
That's
your
it.
bones now. You might
Yeah.
discover it.
Yeah.
Josh?
Yeah, I guess similar. I did not begin my career path being like, I'm gonna do something that's doing anything with bones. I'm a muscle physiology and exercise guy, and My PI, my supervisor for my research project, also is a muscle physiology and is now in chronic pain. And it just ended up that there was a really interesting project that had to do with bones. And so yeah, I was interested and I was on board. So if yeah, it was just an interesting project.
That's good. Stay open to all the options, what we're saying.
Yeah.
Erlene, how about you?
I also didn't start out with rheumatology. It's just, the progression of your career path brings you to certain things and makes you interested in different ways. So I actually, as I explained in the beginning, I started with UHN for about 7 years, navigating the different departments within the nursing career as a bedside nurse or with shift work. Then I got involved in administering biologics. At that time, we moved backwards more than 10 years ago, and I've started doing that outside of UHN and have to learn on how to administer these biologics and doing a lot of readings and training oneself into administration and possibly providing, a safe environment for the patient. Because with biologics, it's always possible that these patients could react anytime. And you have to be like on top of the situation. And then it so happened that there was this position with rheumatology involving that, and it progressed to there. And it's always nice with research that, even before these medications are out in the market, you are actually already providing care for patients that actually need to receive them. Thank you.
You all similarly didn't have an idea you loved bones. This is good. These students are getting ahead of the game. They're trying to figure out if they like them early. All right, we got more chat questions. What do we have here? Oh, this is a nice fun one. What is the favorite moment you've had during your career thus far? Maybe same speaker order to make it easier. Atusa, favorite career moment.
Wow. My favorite, like, it's always when, okay, I love two things. When I'm thinking the same thing that my PI is thinking, that's the best thing, because now you don't have to do the back and forth and do the explanation and everything. So when we're on the same page, PI is a principal investigator for people who don't know. So a PI basically has to take you on. I just saw the comment. So they have to take you on as a student, and that way you can actually like become a grad student. So that's like the most important thing, is to have a PI that supports you. But yeah, so that's that. And also when I get good results. So every time I get good results, I'm just so happy. It just makes everything, I just love it.
I feel
Because
like
it doesn't happen often.
you go like
It's-
through months of nothing, then that one experience
Yeah.
works, and it's like,
I
oh.
was like, yes, it was worth it.
All right, Josh, what about you?
Yeah, that's a tough one. Just I've done so many things before even getting to academia, but specifically in research and on osteoarthritis and bones and stuff. It hasn't been long, but I guess what was the question? The coolest moment? The coolest moment? Yeah, when we collected the data and then, so I can't say anything yet because we have to wait till we do the 12-month follow-up, but it sort of looks like our hypothesis is onto something, at least in, yeah. So it looks like there's something to what we were thinking and what we were trying to investigate. So that was really cool. And I was like, wow, there might be something here. Like, let's get to the 12 months now so we can actually see. And then I guess also just something that is cool and has been cool in the last couple months is just looking at opportunities to build off of the sort of things that we've been researching and putting together. as like, oh wow, this might be a cool direction to take this next. So yeah, the just new ideas and exploring new things which is all the time, but those are the cool moments for me, I think.
It's always nice when like your hypothesis is actually a good one. So it's like, yay.
We still don't know if it's gonna pan out, but it looks like there's something there. So
Okay, Arlene, how about you? Favorite moment, coolest moment in your career thus far?
My favorite moment, I think, is whenever I get the IV line. It's mostly, especially with people that are really very sick, and especially people with scleroderma. And with everybody else too, like I love talking to people. I like knowing people's experiences and their backgrounds, and prior to them being sick, and knowing people like hobbies and dislikes. It's more than a patient in a regular sense. The patients that I see them monthly, weekly, like many times in a year. So it's more than I believe a patient to nurse in to consider the relationship there. But yes, I'm always being joked upon, like, okay, get the IV, do the blood work. It's like I cause pain to alleviate pain. So I'll leave it to that. Okay, thanks.
It's pretty interesting as well. It's a nice different contrast to the hypothesis, talking to your supervisor. Cool moments. All right, we have a bunch of one-on-one questions, so I'm just gonna maybe go through them. Josh, the first one I have is for you. What did you do and learn in the few years off of school before doing your undergrad?
Before doing undergrad, the first thing I think I learned was I'm glad I didn't go to school for the first thing that I thought I wanted to go to school for. I was thinking I was going to go for business and open up I did martial arts for the longest time while I was growing up, for 15 years. And I was like, I'm going to go to school for business and I'm going to open up a martial arts school. And that's what I'm going to do. And yeah, so I'm glad I didn't do that. I still very much love exercise and sports and things, and I did that in school. So yeah, I'm glad I didn't do the sports thing. And then I guess maybe the most important thing that I learned before going back to undergrad was so I worked in construction, and then I worked in auto parts manufacturing for 3 years. And there's good money in construction and working in auto parts, but it wasn't what I wanted to do. So I learned that it's important to do something that you are really interested in and passionate about, even if that's more rewarding than just making a lot of money. Some people like to make a lot of money, but the money wasn't enough to fulfill me over something that I'm really interested in.
So it was worth it.
Absolutely, yeah.
All right, Atusa, question for you. Can you get arthritis from bad posture and heavy backpacks? We're seeing a lot of these like questions in the chat related.
Yeah, I saw that.
It's like
It's like, I'm not a doctor. I don't know. I have no idea. So yeah, I don't really know.
I'll throw something
Can
in
you maybe?
on that one. Specific.
Oh yeah, you would probably know more
I can't
because
speak
you were with it.
necessarily to all types of arthritis, but I suspect they're probably pretty similar. But with NEOA, there are at least a few distinct categories of mechanisms that are likely. They're probably not one or the other. There's lots of interaction between them. It's a very multifaceted condition. But there are maybe the three ones that are most relevant to that question. There's a potential metabolic syndrome phenotype that can maybe related to sort of metabolic bone and cartilage metabolism disruption, and metabolic syndrome specifically being high blood sugar, high cholesterol, or high triglycerides. There's a couple of things that you have to be in a metabolic syndrome. Basically, metabolism is disrupted at some level. And then the other one, well, another one is there's a mechanical loading potential subgroup where typically, at least in NEOA, there is like an injury that causes some sort of abnormal mechanical loading of the tissues that seems to accelerate degeneration and result downstream as osteoarthritis. So from a kinesiology perspective, I would say posture is meant to be dynamic. There's not a good or bad posture. What's important is that you can go into and out of a variety of postures without pain. So just taking a snapshot of someone's posture is very unlikely to be a cause of osteoarthritis. A dysfunctional loading of a joint may over time create some wear and tear that down the road could lead to osteoarthritis. Does that mean posture and heavy backpack will? No, not necessarily, but it's a complex question to answer, but sort of those are the factors that I would consider in that scenario. And I would also reassure people that, again, there's no good or bad posture. It's meant to be a dynamic state. So there's a saying, I can't remember who said it, but the only bad posture is the one that doesn't change. So if you're sitting down for a really long time, stand up for a little bit, get in and out of different postures. Variety is the spice of life.
All right, so don't be scared of your backpack, pretty much. All right, we got a question for, I think it's for Arlene. Is the hat thing for nurses used to protect you, or what is its purpose? I think they're talking about a scrub cap, but maybe you could guess.
Is that with something that I said earlier that the nurses wear many hats?
Awesome.
What I actually was trying to symbolize is nurses do perform a lot of things within the healthcare environment. That's what I actually meant by nurses wearing multiple hats. And I doubt really nurses these days do wear the nurses' hats while going to work. Used to be, I know, like maybe here in Canada, that was way back in the 80s or something. I don't see any nurses wearing any hats except in the OR that we actually need to protect the sterile environment, as we call it, and that's why nurses and doctors and anybody else involved in the OR theater or in the surgical room has to wear the head caps or similar to the shower caps you do at home.
All right, safety is important. All right, I think it's like a general question for the researchy people, but they want to know about your experiments, and then if you have to keep them confidential, like when is the experiment kept confidential? When is it not? Do you have to get special permissions? I guess like that kind of process. I don't know if Atusa, you want to talk about.
Yeah, sure. So you want to keep it confidential because obviously you want to be the first person to publish the data. So you don't want to go and tell everyone about your graphs and like the results that you get and what you did until you publish. With that being said, we actually do go to a lot of conferences and we do like poster presentations. But it's like a vow between researchers to like not use other people's data. The other time that you have to keep something confidential is when you're collaborating with some of the industry people. So if they like create something and they give you like a device, whatever, they give you a device to use during your research. So we still have students that even don't show it to us, like even the lab members. They just say, oh, it's confidential, but like we're using it. So yeah, that was that. Was there another question? That was good. Okay.
Do you want to add anything, Josh?
Yeah, a little different on the clinical side. All patient data has to be kept confidential. So because I'm working with individuals who are going for surgery, I'm meeting them and I'm collecting their physical function data. I'm collecting pain sensitivity data and questionnaires about their well-being and how they're interacting with the world and things. All of that has to be de-identified. So all of the data that I collect from them, their name and nothing that would identify who that person is is allowed to be kept with that data. So everybody gets a unique ID number. So when we're looking at the data, there's no patient information on it. And then, yeah, especially within UHN, there's very strict patient confidentiality.
Yeah, I was gonna say the same thing.
Yeah.
Like we have to do learnings, like online learnings, to like make sure we don't do the stuff that we don't have to.
In terms of the results, though, if we want to, before it's published, if we want to talk about it at a conference, we can. But there's always, before it's been peer reviewed and things, you probably want to hold on to it before it's published and been peer reviewed. The peer review process takes what we've done and sort of verifies that we did a good job. It sort of is legitimate, and we didn't just make stuff up or take something from somebody else.
I guess the kind of question related to, I guess, the research and having a project, the students want to know, like, how do you even come up with a project? Do you just like pick a disease and start researching it? Is it your supervisor? Like, how does your project start, or where does it come from, the idea?
Okay, I can start again. So, for me, it was pretty interesting because I didn't really have that much experience in the lab before I actually volunteer. So for my master's, it was mostly my PI that kind of came up with the project, and I kind of followed whatever she told me to do, which was great because I was, just learning about different things. I was just learning during those 2 years how to think scientifically, how to ask questions, how to answer questions. So that was really nice. But then for my PhD project, because now I had all that knowledge, I kind of decided to get involved more. So I would, voice my opinions and say, this is the experiment that I designed. I want to do ABC. I want to look at this, this, this. Yeah, I want to do like this injection, this treatment. So it really depends on how comfortable you are. And it also depends on the PI, obviously. I know that some of PIs are very open to new ideas, and I was very lucky to have a PI like that. So yeah, you just have to see how it works with your PI.
Yeah, so similarly, I'm in my master's now. Masters are typically shorter term, so PIs typically have a project that is that you're going to work on, and then depending on how comfortable you are and how open the PI is, as Tusa said, you can sometimes collaborate a little bit and get some of your own stuff in there. But master's projects are typically 2 years, so it's a pretty quick timeline to sort of be creating something from scratch. Whereas once you transition, if you decide to do a PhD, you have a lot more freedom. So I'll be starting a PhD next fall, and they approached and they're like, hey, we're doing a collaboration with McMaster, and we want to do exercise and chronic pain. You are into both of those things. Put together a proposal. And so I put together a proposal from scratch, and I used some of the stuff from where we're starting. But so depending on what stage you're at and how collaborative the PI is, you can have for a lot of freedom, or you kind of get given a project, and yeah, it ends up working out hopefully.
It's a collaboration. You sometimes have ideas, but your supervisor really helps you form those ideas.
Absolutely, yeah, and that's what they're there for. Especially in a master's program, very much guidance.
All right, we have a question for you, Arlene. So they saw that you've been at UHN for a very long time, and they would like to know, how has your kind of job changed? Are you still learning things constantly, or did you just become an expert and now you know everything? Like, how have you changed over your time at UHN?
Yes, time with UHN, it's ever changing. As you know, healthcare doesn't stay still, and we have researchers here with our 2 panelists too as well, right? So healthcare do change, and you can never be satisfied with just staying put, or medical conditions also change. At some point, you have to, and with all healthcare professionals, we are bound by our healthcare professions to pursue higher learning in terms of maybe proceeding to masters, nurse practitioners, higher degree like PhDs, and with the two panelists that we have here, Josh and Atusha, right? So you can go that pathway. I can go that pathway too. But at the moment, I am pretty much involved in a lot of other things within rheumatology. And from caring at the bedside, you can move on to different things. Within UHN, there is always a career pathway. And if you do become a nurse, or if you are planning in the pathway or becoming a nurse, there are many pathways too as well. Just like Josh didn't, he wasn't sure at first if he wants to do one thing or the other. With nursing, it's similar. Like there are other people that don't precisely start with a nursing course in a college or university. You can even do other science studies if you have an inclination to proceed into medicine. So you can be involved in a lot of different pathways. Coming from grade 11 and 12, I just do suggest you start early on with your sciences if the career pathway you would like to take on is with healthcare. Thank you.
All right, we're kind of running out of time, so I'm going to ask everyone to answer one last question. And it's a very simple, but maybe not simple question. Do you have a one-sentence piece of advice for these students thinking about what they want to do? Some of them are in high school, some of them are maybe beginning of undergrad. So do you have one sentence? It's very hard. Piece of advice. And Atusa, you have to go first, unfortunately. Good luck.
I don't know. I mean, they're already here. I would say the fact that you're interested is great. That means you care about your future. So my sentence is that keep finding connections and talk to people to get their advice. That was like three sentences.
You have a few ands in there. It's fine.
Yeah. Yeah.
All right,
That was
Josh, what about you?
That was pretty good. I would also say like engage with lots of different people is a great advice, but keep your options open. Don't if you have an idea of where you want to go, great. But try not to sort of like put up barriers in the future, because as things change, as you grow, you might want to pivot a little bit, and just keep your options open.
Good. That was pretty short as well. Arlene, what about you?
I was about to say what he said, Josh said, like keep options open. Cheers to what you have planned, move on. And there are a lot of pathways and you can do it. Put your heart into that. Thank you.
Like a nice little sum up of this whole thing today.
Mm-hmm.
All right, I am just going to do a couple of wrap-up slides. Trisha, as I'm doing these, can you launch the exit poll? We just want to know if you learned something. I mean, I hope you have, but we're going to ask you if you have. All right, so thank you again for coming to our event. So for those of you that are here for the first time, I think maybe half of you are here for the first time, our team is UHN STEM Pathways. So we're the outreach organization for the University Health Network. So we host both virtual as well as in-person events. So you've met some of the panelists here. We do also host tours of spaces at UHN where you can meet some individuals, maybe not these panelists, but other individuals, and chat about what their career is like in person. So you can look up all these opportunities on our website at UHNSTEMPathways.ca, or you can also contact us through any of our social media platforms. We have our email, our Twitter, or X, as well as our LinkedIn page.